Okay, well, let's see. I think people are trickling in as the session is about to start. And so I just wanted to say hello to everyone and introduce yet another edition of our New England Regional Sleep Seminar Series. And I'm really pleased and really honored to have today's speaker and Dr. Javaheri, who will introduce our speaker today. Just as a reminder, this is a seminar series that is run jointly by our Yale School of Medicine, the several Harvard schools in Boston, Tufts Medical Center, Boston Medical Center, and now recently joined by the Brown Medical School. And so we are excited to host this and have been breaking attendance records over the last few months. And so without further ado, I'm going to ask Dr. Javaheri to introduce Dr. Winkelman.
Thank you so much. Dr. Winkelman is a renowned professor of psychiatry at Harvard Medical School and chief of sleep disorders clinical research program in the Department of Psychiatry at MGH. He is a beloved mentor to many in our sleep fellowship program. He has a PhD in psychobiology from Harvard University and his MD from Harvard Medical School, and he did residency in psychiatry and fellowship in sleep medicine at MGH and has done research on the epidemiology, physiology, and cardiovascular consequences and treatment of restless legs, as well as research on neurobiology and treatment of insomnia. And he has chaired the practice guidelines for restless leg syndrome for the American Academy of Neurology and Sleep Medicine. And he is currently chairman of the International Restless Leg Syndrome Study Group. In all, he's published over 200 articles, reviews, and chapters. And I just learned is writing for JAMA for their narrative on restless legs for the month. And I'm very excited to hear him give us updates on the new guidelines for RLS as well as guidance on treating refractory RLS.
So go. I'm gonna see whether I can share now. Yes, I can. Let's get away from HIPAA there. That's not good. And this should be visible. Is my first slide visible, Andre Sogol?
Yes,
Great.
sir.
Okay, so Deb asked me to give a talk. I couldn't remember what I had talked about last year, and then I went back and it was about a question that has been on my mind a lot. Are hypnotics addictive? And so I'm going back to RLS this year and getting away from that thorny issue of hypnotics addictiveness and getting onto a less thorny issue of opioids. Hard to believe anything could be less thorny than that. And here's my disclosure slide, and do with it what you will. I'm going to divide this talk into two parts. One on the new guidelines that the American Academy of Sleep Medicine came out with, and the second on my recent data from the National RLS Opioid Registry. And as you can see, this paper was published in January in JCSM and is the 5-year work of this group of individuals who are authors on the screen. It was a wonderful task force group of experts in RLS, experts in grade methodology. I want to thank Dr. Falk-Yitter, who's a grade expert, and members of the American Academy of Sleep Medicine board who assisted with this, and in the end convinced the board after it was a very unpleasant experience presenting these guidelines to the board because it was a little bit like having a colonoscopy because we had a number of board members who were displeased with these guidelines. And in the end, change is hard, which is what I concluded and spoke to them about. And in the end, those members approved this. So the grade methodology is you can't just do guidelines and choose however you want to do it. You do it according to the group's chosen method of providing guidelines. And AASM uses something called grade that stands for something, and I don't know what it is. But in short, it evaluates this balance, which in the end is somewhat of a judgment call between the beneficial and harmful outcomes that you have identified as critical outcomes within the overall certainty of the evidence. And there are only 4 options in grade that you can come up with. Well, there's really a 5th, which is you're not going to have any opinion because they don't feel there's enough evidence, but only 4 options. And those are either strong for, conditional against, or strongly against, balancing benefits and harmful outcomes. It does not provide an algorithm of first line, second line, which everybody's looking for, but you might be able to infer those things. Let's look at what the implications of these grade recommendations are. So a strong recommendation says almost all patients should receive this course of action. A conditional recommendation, either for or against, that most patients should receive this course of action, most, either for or against. However, different choices may be appropriate for different patients. And no one's taking your MD or NP prescribing privileges away from you. The clinician with the patient and shared medical decision-making must help each patient determine if the suggested course of action is appropriate for them. So conditions, I've just made this really short here. Conditions for or against treatments do not require or prohibit their use, specifically here in RLS. I'm not telling you what you need to do or can't do. I'm just making a strong recommendation. So these recommendations start with what are called good practice statements, which may not have the strongest evidence for them, but we feel are within the context of treatment are important to recognize. And certainly when you see a patient with RLS, first thing you want to do before you start adding things is seeing if you can modify existing approaches to attenuate or mitigate their symptoms. And those would be, in particular, alcohol is a strongly worsens restless legs, antihistaminergic agents, centrally acting ones, serotonergic reuptake inhibitors, dopamine antagonists, withdrawal from opioids, which I won't talk about much, even short-term withdrawal from opioids a month after surgery, and you've been on oxycodone 5 QID, and you stop it abruptly, can lead to a dramatic worsening of RLS, or can bring on previously non-existent RLS, untreated OSA. So treating OSA is important. Obviously, evaluating serum iron indices. You need to always get 3. See 3 fingers here? I like to do the fingers with patients. And it's important when you do the fingers that when you're ticking them off, you don't end up exposing the wrong finger. So always start to this one, then that one. So always do 3. Don't just get ferritin. Ferritin is a non-specific indicator of iron status. So ferritin, iron, TIBC, and counsel the patient that they should not have any vitamins that contain iron or any red meat for 48 hours before the blood draw. I say to them, Ms. Smith, I want your iron level. I don't want a hamburger level. So no red meat for 48 hours before. And they may remember the hamburger level thing and therefore may remember it instead of forgetting it. And we reached this conclusion about considering supplementation, either oral or IV, with ferritins less than 100 and TSATs less than 20%. This is controversial. I'm also on another group that's coming up with guidelines, and in that group, they're recommending supplementation with ferritins less than 300. But the vast bulk of the evidence suggests that IV iron can be helpful with ferritins less than 100. We don't have so much data between 100 and 300. So let's go through top line, or is it bottom line? I never know on these recommendations. So strong 4 recommendations present. We're just going to look here at the first column. We don't have to get into all the data here, but the gabapentinoids, or the alpha-2 delta calcium channel ligands, gabapentin, gabapentin N-acarbonyl, and pregabalin, strongly recommended for RLS. You might even say first-line therapy when you're going to prescribe. Similarly, IV ferrocarboxy maltose, and as we will see, other IV iron formulations we could probably put in here because they have similar features in terms of dissociation once they get in the blood, but just don't have as much data for them. So IV iron and gabapentinoids for first line or strong recommendations. Conditional 4 recommendations. Another IV iron formulation, low molecular weight iron dextran, which is a single infusion, whereas as can be ferrocarboxy maltose. I prescribe mostly at MGH ferromoxetol, which is ferraheme. It's 2 500 milligram infusions, so that's annoying. We recommended against iron sucrose, which is 200 milligrams of iron given 5 times, because the data was negative for that product. Mostly, we think, because the iron dissociates very quickly in the blood and then gets excreted by the kidneys very quickly. And after iron sucrose, people can describe their urine as actually kind of rust colored because there's so much iron in it and it's gone so quickly. The other iron formulation we conditionally recommended was oral iron ferrous sulfate. We included dipyridamole as a conditional 4, even though there's just one randomized controlled trial. I'm not sure that all guidelines would recommend that to this extent. Low-dose opioids are recommended for restless leg syndrome. You notice, even though the randomized controlled trial really was with oxycodone, which was a very large trial and very successful, we extrapolated that to all mu agonist opioids. And finally, perineal nerve stimulation, we had conditional recommendation for, although this is in the context of lack of response. The FDA said this is for lack of response, those with lack of response to other approaches. Here's the big news, and this was the difficult part of my meeting with the board and has continued to be a difficult issue as I discuss this with providers all over the place. Dopaminergics are no longer recommended for restless leg syndrome. We recommended, the task force recommended conditionally against the use of dopamine agonists because of augmentation of RLS symptoms. So we recommended against their standard use for restless leg syndrome. And you can see here these asterisks, which I'm going to read out loud for those of you who can't read the small writing. Patients who place a higher value on the reduction of RLS symptoms in the short term, a higher value in the short term, and a lower value on adverse effects, particularly augmentation, could select these medications for RLS treatment. Again, nobody's prohibiting or requiring anything. We're just making recommendations that these should not be used as standard treatments. Why were the dopaminergics changed to conditionally against? The task force at the very beginning identified augmentation as a critical outcome. And therefore, we were going to balance that against the short-term benefits. And this produced a corresponding reassessment of the relative risks and benefits of this class of medicines. Can't remember what I have next. Okay, for those of you who are unaware of what augmentation is, I think that's very few of you who are listening, but augmentation means to make bigger. And dopaminergics over time for many people make it RLS bigger, both temporally and anatomically, time-wise, expanding the number of hours in which individuals are vulnerable to symptoms, and anatomically, moving from the legs to the upper extremities. Symptoms also become worse, or can become worse. And so I found this little, I don't know what you'd call this, some kind of little picture. Young people must have another way of describing these things, GIFs or something like that. Little picture here. When you take a dopaminergic agonist, I liken it to swallowing a stick of dynamite. You don't know how long the fuse is, and it's possible that it may not go off, but for most people, it's going to blow up on you. Fuse is not short. A year, 3 years, 5 years, 8 years, maybe 10 years. But when we prescribe these medicines, we're oftentimes giving them to people who are 60 years old, who probably have 20 to 30 years of life where they're going to have restless legs. And so we need to think in that context. And I feel particularly personally that this message is important because the pivotal trial for the approval of pramipexole to the FDA, I was the first author on that pivotal trial, published in Neurology in 2006. Fantastically effective. It was a 12-week trial. I don't know how I thought it made sense to use a 12-week trial for approval of a medication that would commonly be used for 5, 10, 20, or 30 years. It doesn't really make sense. And I'm going to chalk it up to my naivete. I don't think there was anything else, you could call it ignorance, that anything else that accounted for that. But I do feel that I'm kind of doing some atoning or penance for that short-sightedness that I made back 20 years ago. So I wanted to look to see what percentage of people in the United States, how common the dosing was for dopamine agonists. So I got data from IQVIA, which you may or may not know is keeping track of every single prescription you write. Sogol, everyone you write. It's all de-identified. Patients are de-identified. I think doctors are identified. But we also have information on diagnoses. So I excluded anybody with Parkinson's disease and looked at everybody who had a diagnosis of RLS taking any kind of medication for it, 670,000 people, 400,000 of them taking a dopamine agonist. About 20% were taking dopamine agonists above what the FDA considers is the maximum dose for restless leg syndrome. And in fact, I made probably a poor decision in that I identified pramipexole maximum dose as 0.75 when in fact it's 0.5. And if we look at very high doses, more than 150% of the maximum dose, 10% of people taking above that level. These are high doses of these medicines, well above what should be used for restless legs. Only one reason people get to those doses, they have augmentation. So dopamine agonists, oh, I like that. There was a little, it came in slowly. Dopamine agonists are seductive because they work so darn well. They're like, us doctors are like rats pressing the bar. And each time you give them to somebody with RLS at the beginning, good things happen. And back in, 10, 15 years ago, chocolates, candies, flowers, it was fabulous. But if you prescribe them for RLS, and maybe in some patients it's appropriate, and I certainly have patients on them, you absolutely need to warn about this complication. If you don't, and if you don't document it, the time will come when this may not be good for you. Certainly not for the patient, but may not be good for you. So always document a discussion about the risks of augmentation. And at each visit, which really should not go more than 6 months between visit, you should evaluate the 24-hour distribution and anatomical distribution of symptoms, trying to see whether there's any indication of augmentation, because augmentation inexorably, insidiously just progresses. I'm not going to talk about, I should talk about pediatrics. There's very little about RLS in kids. So all we could come up with was a conditional recommendation for POs ferrous sulfate for kids with restless leg syndrome. There just wasn't enough evidence otherwise. We may have increasing evidence for IV iron in the coming years. So that's going to be it for the AASM guidelines. And so I've got a good amount of time to talk about my ongoing project, this registry project, which informs some of my thinking about opioids. And I feel like kind of once burned with the dopamine agonists, and I started prescribing and thinking about opioids. Fool me once, well, however the saying goes, I can't remember, but fool me twice, it's my fault. So I wanted to get a good idea of what the ongoing risks were, particularly for dose escalation with the opioids and RLS. The biggest concern both docs and patients have about this class of medicines, particularly in the current environment. Though, before we get to the registry data, I do want to promote this. RLS Curbside. This is a Neuroscience Foundation funded website. And here you can see the QR code that is absolutely free, HIPAA compliant, free of all commercial influence. And we developed this a few years ago. It is like a Reddit forum where if you have difficult RLS patients, you do need to register. You do need to be a provider to get into this. This is not for patients. And once you're registered, show your medical license, you get approved. And then there's a quick little template where you put information about the patient and what you're struggling with, about what to do for this RLS patient. And at this point, there are about 250 registered individuals who will then share their thoughts about what the next steps are. And so this has grown over the couple years that since we developed it. And I think it's a nice tool because we don't see each other enough. It's hard to curbside somebody who's at home when I'm at home. And it used to be that I'd just ask her to chat with me about a patient that I was concerned about and say, could I just pick your brain for a minute? And now that's less available. And so we do things online. And this is a very nice way of talking to other providers about difficult RLS patients, RLS Curbside. So hit the QR code if you're interested, register, and then welcome aboard. So the National RLS Opioid Registry, the plan for this was to, as you may know, a registry is an observational longitudinal study. So long-term evaluation where you're just watching. And wanted to see how people were being treated in the US with opioids for RLS and generate data and hypotheses about the longitudinal efficacy of these medicines. Importantly, whether doses increased, whether what happened to concurrent RLS medicines, what the side effects were, and whether those changed over time, and then a variety of additional metrics on sleep, mental health, physical health, et cetera, et cetera. So this is how it went. We initially got funding for 200 individuals, and we got overwhelmed. About 5 of these patients, maybe 10 of these patients are my own patients. All the rest come from other providers around the United States, enrolled through the RLS Foundation or RLS Quality Care Centers around the country. So we got overwhelmed with requests to participate, and so we kept increasing it. And at 500, I said enough. And all people had to do to get enrolled is they had to have a therapeutic response to dopamine agonists. I wanted to, in addition to the initial phone screen and interview we did, I had to be convinced they had restless leg syndrome. And so they had to have responded to an agonist. And they had to be taking daily opioids for RLS. And so we did these initial interviews back in 2016, 2017. And then every 6 months since they've enrolled, they have filled out very elaborate red cap surveys that take anywhere from 15 to 30 minutes. And we've been really, really lucky that the participants are extremely loyal to this process. And we send out quarterly newsletters about it to encourage it. And people who are behind are also lucky because they get a telephone call from Dr. Winkelman saying, Mr. Jones, I see that your survey was due a month ago. I'm wondering if everything's okay with you and if you want to continue in the registry. And people usually are quite responsive. Unfortunately, we've had many people be sick, and so they've had to put it off, but very, very loyal participation. We've already published 2 papers from this, 1-year data in sleep and the 2-year data in neurology, and I'm going to present the 5-year data here, which has just been submitted for publication, and hopefully you'll be seeing it in print soon. So at baseline here, you can see geographic diversity of the patients. The darker blue means more people, a lot of people in California, and a bunch all over the US. And here you see little teeny Massachusetts, maybe with 10, 15 people, something like that. About 60% were female. You can see it was not a young population. Anybody who's treating a lot of RLS will recognize that they are geriatricians. I wanted to be a pediatrician when I first got to medical school, and somehow now, I look down my list of patients for the day and everybody's in their 60s and 70s. Not that there's anything wrong with that, of course. And so 3/4 were over 60. It is a thin slice of overall population, and that 98% are white. A significant percentage are well educated. About 2/3 have a family history of RLS, about 40% with a history of depression, 30% with a history of an anxiety disorder, 22% have a history of active suicidal ideation. And we use the Columbia Suicide Scale, and almost all of the suicidal ideation was related to their poorly controlled restless leg syndrome. We did the opioid risk tool, which you may be familiar with, which is not validated, but it's the most commonly used tool to assess risk of misuse or abuse of opioids, and 3/4 were at low risk of opioid misuse or abuse. So you see on the right side here, these are people who were already on opioids. And the most common duration of time that people had been on opioids at baseline, at enrollment, was 1 to 3 years. But otherwise, we had quite a distribution. We had about a quarter of people who had been on opioid less than a year, and I don't know, about 40%, maybe more, who'd been on it more than 3 years. What was the most common opioid was methadone. About 50% of people on methadone, about a quarter of them on oxycodone, about 15% on hydrocodone, 10% on tramadol. So this was the population, the cohort at baseline. And here you see dosing, the median baseline dose, and we converted all opioids to morphine milligram equivalents, because this is how you make sense of somebody who's taking oxycodone, somebody who's taking tramadol, somebody who's taking buprenorphine. You come up with an MME. And so this was about 6.4 milligrams of methadone at baseline, 20 milligrams of oxycodone. Low dose. For those of you who are unaware, for opioid use disorder, or for people in chronic pain, let's say due to cancer, often methadone doses are 100 milligrams or more. For buprenorphine, common doses for restless leg syndrome are oftentimes around 0.5 milligram. For opioid use disorder, they're 16 to 24 milligrams. So this is, whenever I use the word opioid, I try to add the words low dose in front of it, because these are low doses. About 80% have MME less than 50. So that's about less than 10 milligrams of methadone and probably around 30-ish milligrams of oxycodone per day. But 1 in 6 people still said they had severe, very severe symptoms. And here you see the distribution of MME at baseline. A lot at the low dose and a tail here. This is as of April. I should have updated this. I apologize, because it's now October. And so this is where you can see kind of like a consort diagram, if you will, about 500 people initially. And we're now, at least in April, about 125 are now probably 150 have completed the 7-year surveys. We've completed surveys for everybody at 5 years. And I think now we've completed everybody at 5.5 years. Where did the 90 people go who started from 500 to 410 at 5 years? 18 had died, 38 had stopped their opioid, 9 withdrew voluntarily, and 20 we just couldn't find. They were lost to follow-up. They may have died. When people don't respond after a time, strangely enough, we go and search obituaries to see whether they've died. But they may have just stopped answering. So that's where the 90 have gone. Now we've got 5-year data, which is what we're publishing now. And here you see the overall statistics. About 30% of people remained on the same MME as at baseline. 50% increased their MME by a median of 15 MME. So in terms of methadone, that's 3 milligram increase of methadone, 10 milligram increase of oxycodone, and 20% decreased their dose by the same amount. And here you see histogram of changes from baseline to year 5. And you can see here are the decreasers, here are the increasers, here are the ones at stable MME. And what we've been most interested in are these people. Hopefully you can see my cursor out on the far right end. These are the ones that concern me when I'm going to start an opioid. Are people going to stay at a stable dose? Or after a couple of years, am I going to have to increase? And then a couple of years later, going to have to increase again. Getting to doses that make me uncomfortable and put the patient at greater risk? What is it that predicts or is associated with these large increases? So before we get to that, you can see here individual drugs on the left, the baseline count, and the baseline milligram average dose. So for instance, 200 out of the 500, we're taking, well, now this is of the 410 at this point. 200, we're taking methadone at baseline. Some people switched from another opioid to methadone, so they're more, and you can see the average dose went from 10.9 milligrams to 12.5 milligrams. 12% of the people who were on methadone at baseline decreased, about 30% increased, stayed at the same, and about almost 60% increased. And here's the distribution of MME increases. What is notable was that the biggest bump in terms of what opioid people are using has occurred with buprenorphine. Only had 14 people back when we enrolled for the study, for the registry. Now there are 45. Buprenorphine has become more popular as a first-line agent and as a switchover agent for individuals using low-dose opioids for restless leg syndrome. And so, and quite a bit of variability in dosing. So a third of people decreased their dose from baseline, and a quarter of people increased their dose from baseline. And we'll look and see, and buprenorphine is really something to watch because it accounts for a substantial percentage of the individuals who had a large increase in their MME. We did a really kind of fun statistical method here. There's something called trajectory modeling, where you take large groups of people and look at change in an endpoint and group the individuals based upon the trajectory or the change over time in some variable, here being their MME. And we had 3 relatively distinct groups that came through in trajectory modeling. We had 3/4 of the individuals who had no or little change in their MME, 1.2 plus minus 10 of their MME. We had about 20% of individuals with a small increase in their MME, about 30 MME increase, which would be around 5 to 6 milligrams of methadone, and then a very small percentage of people with large increases. You might notice that this only adds up to 97% for those of you who like doing quick math. There's a group of people who had decreases, but I'm not including them in this graphic because it makes the graphic less pretty, and I just love how this graphic looks just like this. And so I'm sticking with this one until the editors tell me that I have to include the decreasers. So we then looked at increasers in 2 ways. One, this group of large increasers, and individuals who increased their MME more than 50. So those are 2 different ways of looking at increasers. And we wanted to look at the associations, the independent associations by logistic regression at those folks. So here's the, based on trajectory analysis, we looked at the percentage of people in the no or little change, those in the small increase, and those in the large increase. And what you see is that really the strongest predictor of those individuals in the large increase was people who had switched to buprenorphine. It's a little bit difficult to really establish this because the CDC has now said they're not going to provide an MME for buprenorphine anymore. They come out every few years with new or improved MMEs for the different opioids, and they said we're not going to provide them for buprenorphine because it's a mixed agonist-antagonist, and it's super safe much safer at very high doses in terms of overdose. So we're not going to come up with an MME. However, for my purposes, I needed some metric, so we used the previous MME of 30 MME per milligram of buprenorphine. Other than that, this red square these are all offset. This red square is supposed to be there. This big red square is supposed to be there. So you can see also people who switched to methadone had an increase in their MME. And this was supposed to be there. Everything got offset here. And those with more severe restless leg syndrome at baseline, also, that was a predictor of large increases of MME, which you might expect. People who had severe illness at the beginning might have to increase their dose. Now we look at a fixed cutoff of 50 MME increase. So that would be about 10 milligram increase of methadone, about 35 milligram increase of methadone, of oxycodone. And what are the predictors there? And by far the strongest, again, is people that switch to buprenorphine from another opioid, using an MME of 30 for buprenorphine. So these are people, so the question is why, what is it about buprenorphine? And I don't really know. Why are people using higher equivalent doses of buprenorphine? Maybe the MME is wrong. Maybe the CDC is correct that the MME is just can't really be provided for buprenorphine. It might be that the smallest pill of buprenorphine, remember you take buprenorphine or Suboxone sublingually, because if you swallow it, it gets metabolized in the liver and inactive. So you have to have it absorbed buccally or sublingually or transdermally. So it bypasses first pass metabolism. So it may be that, so the smallest dose is 2 milligrams. Breaking a pill in half to 1 milligram is possible. Anything smaller than that is really not possible. So when I start somebody on Suboxone, I give them these films that, again, they put under their tongue. The smallest film is 2 milligrams. And I have them cut it into eighths. An eighth of a 2 milligram film is 0.25 milligrams. Remember, people using buprenorphine, Suboxone for opioid use disorder are using 16 to 24 milligrams. I'm starting people, and most people, a lot of my patients are ending up at 0.25. But it may be that a lot of providers aren't aware that you can use the films or that you can cut them that small. It's not easy, but patients are doing it. And so this may then inflate the doses that are being used. Also, if you read the data on buprenorphine, its absorption and bioavailability is quite wide, as you might expect. You put something under your tongue, and I have patients that say, doc, it's under my tongue, but then I think I swallow it after about 15 minutes. Or, I have a drink of water afterwards, and then it's gone. And so when you look at bioavailability studies for buprenorphine, it's quite variable. Here's the range of IRLS scores in the from baseline to 5 years in the registry. And you could see relatively stable. The IRLS is actually pretty much absolutely stable, but there are some changes going from about 22% to about 12% with no symptoms, but a big increase in people with mild symptoms and decreases in those with severe symptoms, moderate to severe symptoms. So overall, IRLS is stable, but there's actually some fluctuation. And RLS, as any of you know who treat RLS, has tremendous variability day to day, week to week, month to month, season to season. So we're just taking snapshots. This is a 5-year snapshot versus a baseline snapshot. And finally, we looked at side effects, and we have a whole list of side effects that we ask about, and you can see that they're pretty stable. A little bit less people with, fewer people with constipation. Constipation is almost always manageable with opioids for RLS, and people may just be learning how to manage it. Fatigue about stable, itching about stable, sweating about stable. So I think I'm going to end on that note and see if there are any questions from the audience. It looks as if there's a fair number of folks out there, which is really nice. Selgal and Andre, you've done a remarkable job of expanding this beyond just our 2 little institutions to a variety of other institutions, and allowing us all to learn from everybody at all these great places. So thank you for your work on this, and I appreciate everyone's attention.
Thank you so much, John. I have to credit Andre with the expansion and his team with this expansion, and that we're all benefiting from it. So thank you. And thank you for this phenomenal talk. I have a few questions of my own, but I'm going to start with one in the chat. Ting Chen is asking, does augmentation reverse after discontinuation of dopaminergic agonists?
Yeah, a very important question. My experience, and I think the experience of many of us who treat augmentation, is that the dopaminergic system is a learning system. Our brain dopaminergic system learns. You know, when you ask rats to bar press and they learn to bar press for certain things, it's the dopamine system that's actively involved there. And it learns and doesn't forget. And unfortunately, we are stimulating the dopamine, or fortunately, maybe we're stimulating the dopamine system with these agonists. So really the best way to answer that is if you have somebody who's augmented, you switch them, let's say, to an opioid, and a year later you say, let's see what happens if we now switch you back to an agonist, which, you know, some of us certainly have tried to do. The agonist works well again for a short period of time, and augmentation quickly returns. So I would say it's not reversible. Another way to evaluate it is somebody started with symptoms from 10 p.m. to 2 a.m. They get augmented back to 2 p.m. So now at work, they're at a standing desk, driving home, they have to get out of the car, you know, all the usual things. And now you're treating their restless leg syndrome. Do you have to treat from 2 p.m. all the way all night long when their symptoms were initially? Or can you really just treat from 6 or 8 p.m.? Has the shape of the RLS returned closer to where it was? And it's hard to answer that question. I think it does return in some respects to its original form, but certainly not back to just a couple of hours a day to where it was. So there is a lot of plasticity in this system, but once it has seen dopamine agonists and has modified the disease process, there's not going to be a ton of change just being off the agonist, unfortunately.
Do you know for augmentation with spread of symptoms, does that reverse if it's in their arms and you wean off the dopamine agonist? Do you know if that lessens, or is that unclear?
I think it's unclear. I'm not sure it's clear. The problem is you're treating all these people.
Mhm.
You know, so you're treating them with pregabalin, or you're treating them with an opioid or gabapentin. And so it's really hard to see what they are native, what their persistent RLS is. But in my experience, it oftentimes continues in the upper extremities, but with treatment, it can be decently controlled. Those upper extremity symptoms are really bothersome to people. You can walk off the legs, but people just don't know what to do with their arms to manage those very uncomfortable symptoms.
The next question says, from your data, over 300,000 patients with RLS are prescribed dopamine agonists, and now that they're no longer recommended, what do you suggest patients should do who are not experiencing augmentation, who are on a stable dose of a dopamine agonist? What's your recommendation for them?
Well, this is what doctors do. We talk to our patients about the risks and benefits. And we say, you've been on this medicine for 3 years, you're at a stable dose. There's no evidence of augmentation at this point in time. The likelihood is that over the next 20 years, you will develop some augmentation and maybe substantial augmentation. But you're doing well now. And let's think about this together. There's the risks of augmentation. Then there's the risks and the unpleasantness of coming off the dopamine agonist. And it's not easy. I say you're going to have to detox off this. And it's going to take us 6 months to get you off. And we're going to be adding the new medicine on first. And you might have side effects from the new medicine. And here are the options of the new medicines. And here are their side effects. And we have a discussion together. And I document that and I see them regularly. So I think that this is the good old, there's now a term for it, shared decision making. I thought it was just called being a doctor, but now it has a nice name to it. And you do that with people, and I'm not going to force them one way or the other, but certainly if they're at a high dose above FDA recommended maximum, I'm going to strongly encourage them, even if they're not augmented, that we need to reduce the dose because higher doses lead to increased risk and severity of augmentation.
So the next question, Katie Sharkey, thanks you for a great talk and your important work in changing these treatment recommendations in response to more data, and asks if you can comment on a strategy where a patient is started on a dopamine agonist temporarily to provide quick relief while gradually titrating up on other patients, say gabapentin or something else.
I think it depends on how severe their RLS is right now. If you need to get control, absolutely. Right now, it seems reasonable. If they're, suicidal, as some might be, because they're at their wits' end, they haven't been sleeping. A lot of the suicidality that I see stems from hopelessness. That's why people say, I can't live like this. They can say, I can't live like this. But if you say, I can make it better, then the hopelessness is addressed. So I would first say to them, I know it's really bad now, but I'm pretty sure that we can make this better. Do you want to get treatment now over the next couple of weeks while we up titrate something else? Understanding that we're going to want to probably decrease that acute medication, or can you hang in there while we increase the dose of XYZ? Again, it's a discussion you have with people.
Dr. Jackie Chang is asking what % of those in the registry received IV iron?
Oof. Good question, Jackie. I don't know. I think we have the data on that, but I don't have it at my fingertips. IV iron is getting used, I think, more and more widely. The problem is most docs who order it use as the indication RLS, and then it bounces back from the insurance company. I always use as the indication iron deficiency. I know that Robert Thomas uses disorder of iron metabolism. But the reason why I would say either of those is because restless leg syndrome is probably most likely a brain iron deficiency. And so I feel justified in putting that as a diagnosis. I know it's not kind of what the people intended when they questioned whether it was iron deficiency or not, but I feel justified in putting that, and then you can almost always get coverage.
Is it possible for patients with opioid use disorder treated with methadone, typical doses greater than 80 milligrams and usually dosed in the mornings, to have restless legs? And if so, would you recommend splitting the dosing, i.e., BID methadone, morning and evening?
Yeah, we published a paper on this because I have been very interested in this population of people with opioid use disorder who are detoxing, and we had a NIDA grant to look at people detoxing from opioids who have high rates of restless leg syndrome. And if you talk to them, this is one of the main problems during detox. They say, yeah, I have these cravings and I have these other systemic symptoms, but what really gets me is this terrible feeling I have in my legs. And the only way I know to deal with it is to use. And so we did a clinical trial with pramipexole versus placebo in a detox. And we also, in a separate study, looked at people on maintenance therapy, just like you're asking, with either Suboxone or methadone. And I can't remember, about 10 or 15% of them, even on maintenance therapy, had restless legs. And so, yeah, splitting the dose is a very reasonable option, or giving most of it at bedtime is a reasonable option. But of course, I would look for all the other culprits that we would normally look for in people with restless legs. Look at iron status, look at other medications, dopamine antagonists, serotonergic reuptake inhibitors, alcohol, all the things that could be worsening their RLS, and try to mitigate those as a way of addressing their RLS. But I think splitting the dose or giving it all in the evening is a reasonable first choice.
Dr. Chopra asks, is there something obvious that triggers augmentation in patients on a stable dose of a dopamine agonist, such as acute on chronic iron deficiency and SSRI addition, development of OSA or menopause, etc.?
Yes, all of those. Unfortunately, the best data, maybe the only data, is low iron status. But all the things that can make restless legs worse can induce augmentation in someone who has previously been well controlled. But I'd say the main thing that's going to produce augmentation is father time, repetitive dosing, repetitive stimulation of the dopamine receptor. Think about what happens in Parkinson's disease with levodopa. They don't develop worsening Parkinson's. Well, maybe they do. It's really they develop dyskinesias and on-off phenomena, right? We're very lucky in RLS that we didn't see dyskinesias from the dopamine agonists developing in people with RLS. We just saw worsening of the same disorder we were treating, not a new movement disorder. In Parkinson's, they unfortunately saw new movement disorders. So the main thing is just time. Repetitive dosing is what's going to stimulate, what's going to provoke augmentation.
John, I have a couple questions of my own. One of them was, given the data from your registry that you've analyzed thus far, would you recommend avoiding buprenorphine for treatment of RLS with opioids and preferentially using methadone?
No. I think that buprenorphine's, I don't think there's any superiority of one over the other. There's an advantage for docs and patients in that Suboxone is labeled such that you can write refills, which is really nice. You still have to, at least in Massachusetts, you still have to see people who you're providing chronic opioid therapy every 4 months. Those are Massachusetts regulations. You don't have to see them in person. Hey, Brian. Somehow your face here is right there. Just when I said 4 months.
Every 4 months, that would overflow my clinic.
It keeps me busy, but I get to see the same people over and over again. And it has allowed me to stop seeing new patients because I calculated I have 650 patients, and that's enough. So the original question was superiority. So refills, good thing. Load, you can cut the films. You can use transdermal formulations, which start at 5 micrograms an hour. So 5 times 24 is 120 micrograms, or 0.1 milligram. And so that's an alternative to get really low doses, usually covered by insurance. So I don't think so. I think I'm not sure what to make of that data. I think it may be kind of an artifact. We'll continue to follow it. And the important thing is the people who are on buprenorphine, are they needing to increase their dose over time rather than just the switchers? Because I think the switchers may have ended up with a higher MMA. The numbers now on the people we only had 14 people in 2017 when we started this who were on buprenorphine. So we'll continue to follow those people long term.
John, thank you so much. I just got notified Yale has to start their grand rounds at 3 p.m. So unfortunately, we have to cut the Zoom. But thank you so much for this wonderful talk. Everyone learned so much.
Glad
This
to
has been
see everybody.
amazing. Thank you.
Thank
Thank
you.
you. See you guys all next month.
Bye.
Bye.
Thanks, Dr. Winkelman.
You're welcome.